I send YouTube link to all the in all group.
Dr. Madhuri.
Good evening, sir. Good evening, sir.
Hi, Nishan.
Good evening, sir. Good evening, Madhuri ma'am.
Yeah.
Good evening,
Dr.
Nishan.
Anju joined now. Yeah. Shall we
Good
start?
evening, everyone.
Yes. Good evening, ma'am.
Good evening. Good evening, Anju.
Good evening to all of you. Welcome you all in monthly webinar. First of all, I would like to call Dr. B.K. Prasad sir. B.K. Prasad sir, our scientific chairman, Bihar Jharkhand Society of Anesthesiology. Dr. B.K. Prasad sir, please welcome our chief guest and guest of honor and our moderators and all speakers. Please, Dr. B.K. Prasad sir.
सर अनम्यूट कीजिए.
म्यूट है, आवाज आ रही है?
हाँ बोलिए
सर. अब आ रही है.
सबसे पहले नमस्कार सर. गुड इवनिंग टू एवरीवन. I feel myself honored guest Dr. Naveen Malhotra sir, well known to everybody. Dr. Rekha Das, guest of honor, again well known to everybody in our society. Very learned and very effective. Our moderators, Dr. Madhuri Kurdi and Dr. Anju Gupta. Speakers, Dr. Poonam, Dr. Pankaj, Dr. Babli. The main person of this day, Dr. Jayaprakash, and our president, Dr. Motilal Das, Dr. Ladu Lakra, and our other Dr. Nishant and Ajay Kumar. I welcome you all and all the participants to give your view and learn something from this session and evaluate about the efforts of Dr. Jayaprakash. Thank you, sir. I welcome you all again. Thank you, sir.
Thank you, sir. I would like to.
Thank you, DK sir. And Jayaprakash, please. First of all, I would like to call Dr. Naveen Malhotra sir. Please say a few words regarding our webinar and this topic, sir. Please, Naveen Malhotra sir.
Thank you, Dr. Ajay. Bihar and Jharkhand IACNs. Warm greetings from myself and heartiest congratulations to Team Bihar Jharkhand for continuous organization of academic activities. For the last couple of years, there have been continuous organization of academic activities, whether it is the ISA sponsored national CMEs, workshops, or online programs. The physical activities at Patna, PG Assembly, pain workshop, at Jamshedpur, the CME, and the recently held at Bokaro. And regularly monthly meetings of Bihar and Jharkhand Society of Anesthesiologists. And I feel that these are the perfect preparations towards the most important event, which is occurring after more than 50 years in the state of Bihar and Jharkhand, the ISACON 2024. I've been involved in ISACON 2024, which is going to be held in Patna, Bihar, since its inception. And I'm very sure that it will be a grand event. The whole team is working towards that event and best wishes for the same. The state of Bihar and Jharkhand is my second home. I have visited multiple times. Patna, Gaya, Bhagalpur, Ranchi, Jamshedpur, and other cities, whether for CMEs, workshops, as an examiner, or as an NMC assessor. In this capacity, I wish to be excused that I do not accept your invitation as chief guest. With folded hands, I feel that I am the chief host of today's function rather than the chief guest. So I hope you will all give me that honor to be the chief host of today's function. And in that capacity, I express my deep sense of gratitude to my colleague in GC, Dr. Rika Das, who is the guest of honor for today's academic webinar. Very respected Dr. Madhuri Kurdi, who is the moderator for today's academic session. Dr. Madhuri Kurdi is an active and sincere worker, and she is actively involved in the activities of Indian Society of Anesthesiologists and Indian Journal of Anesthesia. The other moderator for today, dear Dr. Anju Gupta, he is a very bright anesthesiologist who has got numerous publications and books to her credit and numerous awards also, including the recent one in innovation and airway. My blessings and good wishes to all the three speakers, Dr. Poonam, Dr. Pankaj, and Dr. Babli, who shall be dwelling upon the clinical aspects of pediatric anesthesia. And I'm very sure that it will be very nice academic interaction. I also thank the scientific committee of BGSA, led by very respected Dr. B.K. Prasad sir, a very gentle human being. Dear Dr. Jay Prakash and Dr. Nitin Ojha, who are working under his direct supervision. Dr. Jay Prakash is a renowned critical care specialist and is actively involved with keen interest in the organizational activities of Bihar Jharkhand Society of Anesthesiologists. I also thank my brothers since years and years together, Dr. Motilal Das, Dr. Ajay Kumar, and Dr. Lakada and Dr. Prashant for their continuous love and affection. Thank you from bottom of my heart.
Sir,
Bihar and Jharkhand Society of Anesthesiologists has always given jewels to ISA National in the form of past national presidents, vice presidents, and the younger lot, the Yuva stars have taken a lesson from them, and they are actively shining at ISA National. Dr. Nishant Kumar is actively involved in online PG classes. Dr. Abhuday Kumar is actively involved in ISA online quiz, and Dr. Sharad Kumar was recently associated as an academic coordinator in the recently held CRISP series on obstetric anesthesia. And also there are bundles of talent, Dr. Neelam, Dr. Shiopre, Dr. Neeraj, Dr. Sukesh, Dr. Abe, Dr. Basuki, and many more. I may have forgotten many names, but these all team led by our Dr. Umesh Badani, who is the scientific chairperson for ISACON 2024. I'm very sure that all these, under the supervision of elders, will make ISACON 2024 a grand event. And last but not the least, my younger brother and very dear Dr. Manoj Kumar, the honorary treasurer of ISA National, who has always worked, I know he's there, who has always worked for the interest of Bihar and Jharkhand Society of Anesthesiologists, and absolutely it's a brilliant team. So but one thing, just a suggestion. I know Dr. Manoj is now at National, but I didn't find his picture in the flyer. So keep in BGSA also. Yes, he's at ISA National. So I'll suggest that in future flyers, put his picture also.
Yeah, previously, sir, we were putting Manoj was in flyer, but now he is national figure, so we can't put that. And Manoj boss is our big brother, na? So घर की मुर्गी को थोड़ा दाल बराबर वाली कहावतें हो जाती है.
My request is just an input that he is a national figure, but yes, but state में just there's a food for thought. So I once again thank you for inviting me as chief host of today's scientific event on pediatric anesthesia. I convey my best wishes for today's program and for the future academic programs to be held under the banner of BGSA. And thank you for all your love and affection in the past, in the current, and my future endeavors. Thank you very much. Long live ISA, Jai ISCN, Jai Hind. Thank you very much.
Thank you, sir. Thank you, sir. Thank you. Now, Ma'am Rekha Das, ma'am, please say a few words and also introduce our moderator.
Yes. Thank you so much, Dr. Ajay. I feel so small to share this screen and to be invited along with Dr. And Professor Naveen Malhotra, sir. He's such a dynamic person and he has such leadership qualities. And it is really an honor to be the guest of honor in the same platform where he is the chief guest. And I really thank Bihar and Jharkhand branch for giving me this prestige. And I'm also very much thankful always to all the members of the Bihar and Jharkhand for remembering me for any activities of theirs. I've been there several times for any small academic activities. In fact, whenever Dr. Manoj has called me several times, I have not been able to go. And I regret for not going, but due to my commitments, certain important my commitments towards the hospital being in a very administrative post now, it's becoming a little very consuming, time consuming, and also very hectic. So I'm not able to, but I must congratulate the Bihar and Jharkhand branch for coming up with such wonderful academic activities, sincerely doing all the CMEs, the academic activities, the PG assembly. And I think they are very bright and they are no way behind than others. They are one of the forerunners in all these academic activities. And for this, I must always thank the youngster, Dr. Ajay, Dr. Nishan, and their torchbearer, Prashad sir, Dr. Motilal, and Dr. Ajay. And of course, Manoj is always there. And I'm really thankful again from the bottom of my heart. And I'm very happy today that my two lovely academic enthusiasts, Dr. Madhuri and Dr. Anju, are here today to moderate the show. And therefore, all the best wishes to the speakers, Dr. Poonam and Dr. Pankaj and Dr. Babli, for coming up with a very upcoming subject, safe anesthesia practice in pediatric age. With this, I wish Bihar and Jharkhand branch all the best. Thank you. Thank you again.
Thank you, ma'am. Thank you. Now, time to start. Dr. JP. Jayaprakash, please.
Now I would like to give handover to our moderators, Dr. Madhuri ma'am and Dr. Anju. So please, without wasting time, we should now start the session. Thank you. Madhuri ma'am.
Yeah. Thank you very much, Dr. Jayaprakash. And at the outset, I would express my heartfelt gratitude to the ISA Bihar Jharkhand state branch for inviting me for this on this prestigious podium. And I really appreciate you for this very nice theme of safe pediatric anesthesia. And without wasting any time, I think we will move on to the deliberations. I think the first talk is by Dr. Poonam Kumari. Poonam Kumari, she is Associate Professor in the Department of Anesthesiology at AIIMS, Patna. And she will be speaking on the topic, neonates undergoing pyloric stenosis repair are at increased risk of difficult airway management. This is a case discussion. The case discussion will take place for 15 minutes. So over to Dr. Poonam Kumari. Dr. Poonam.
Thank you, ma'am, for such a kind. I want to share my screen.
Yeah, please share your screen.
Yes.
If there is there any problem in sharing the screen?
No, open your PPT and then share. Yeah.
Yes.
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 My screen is visible.
No.
No,
Your
not yet.
Screen is,
No.
You first open your PPT and then, yeah. Now share.
Now it is.
please
it is
go on
visible.
slide.
Yeah.
Poonam, stop
Yes.
sharing first. Poonam, stop sharing first. Open the PPT and then stop.
Okay, okay.
Poonam, open your PPT and then share.
Yeah, make it full screen now.
Ah.
We can see it. Make it full screen.
My screen is visible.
Yes,
Yes.
it is visible, but not the full screen.
Make not from there, from yeah.
Yes,
Now
now
it
it
is.
is.
Yeah, now it
Go
is.
to slide share, then it will be.
It is visible.
Yes.
Now it is fine.
Yes.
This is fine.
Yes. It is fine. You please start now, Dr. Poonam. Please start.
Okay, okay.
Please go ahead.
Okay. Good evening, everyone. I am Dr. Poonam Kumari, Associate Professor, the Department of Anesthesiology, AIIMS Patna. Today, my topic is neonates undergoing pyloric stenosis repair are at increased risk of difficult airway management. What is pyloric stenosis? Pyloric stenosis is the result of hypertrophy of the smooth muscles of the pylorus, which forms the gastric outlet, also known as infantile hypertrophic pyloric stenosis. Pyloric stenosis is a problem that affects baby between birth and 6 months of age. Typically occurs in infant between 2 and 8 weeks of age and affect 1 out of every 500 to 1000 live birth. The risk of disease is 4 to 5 times higher in male children than female. Now I want to share a case. A 25 days old male baby weighed 2.4 kg presented with vomiting after each breastfeeding for previous 10 days and decreased frequency of urine. Non-bilious projectile vomiting, non-bloody vomiting, and vomiting occurs within 30 to 60 minutes after each feed. Persistent hunger was present and child looks lethargic. Full-term normal vaginal delivery and fully immunized. No regular antenatal checkup, no any family history of the same disease, or no any other congenital anomaly present, and history of jaundice is also absent. On general examinations, we found weight is 2.4 kg, length is 49 centimeter, child is conscious, lethargic, and afebrile. Pulse is 130 beats per minute, respiratory rate 40 per minute, and BP is 88 by 54 millimeter of mercury, and saturation is normal. On examination of skin and mucous membrane, sign of dehydration is present, cyanosis, jaundice is absent, face looks normal, no any obvious facial anomaly found, and examinations of head, the head circumference is 35 centimeter, Fontanelle is normal, eyes normal, mouth and tongue normal, neck is also normal and no any cystic swelling is found. Limb movement are present, no single transverse palmar crease seen and no any foot anomalies is found. On abdominal examinations, we found a firm mass the size of an olive in the mid-abdomen palpated. Peristalsis movement is absent. In chest examinations, clavicle is intact, symmetrical in shape, and in cardiovascular examinations, normal heart sound is present and no any murmur is found. The perineum and genitalia looks normal, no any significant findings like hypospadias and imperformance anus. In neurological assessment, cry is present, baby is awake, normal positions, and no any neurological deficit found in the baby. In investigations, hemoglobin is normal, that is 10. Total count is normal, that is 12,000. Platelet count is also normal. And blood urea nitrogen is 20. Serum creatinine is 0.6. On ABG examinations, we see the pH is 7.6. The partial pressure of carbon dioxide is 35, bicarbon is 25, and chloride is 95. Sodium is 130, potassium is 3, and ultrasound of abdomen, the muscular thickness is more than 3 millimeter. The ultrasound is the gold standard for the this diagnosis. This finding related to the pyloric stenosis. So the pyloromyotomy surgery was planned. What is the concern? Mainly related to the patient and surgery. The patient-related concern is the dehydration, metabolic abnormalities, difficult intubation. Why in this difficult intubation? Because the full stomach is present and there are the chances of aspiration, and also difficult IV cannulation. And surgery-related problem is the post-operative analgesia and post-operative nutrition and feeding. Then we go for the anesthetic management pre-operatively. First, we correct the dehydrations and metabolic abnormalities. 48 hours period for correcting the electrolyte imbalance and dehydrations with 5% dextrose in a half normal saline and potassium chloride. When the electrolyte loss, then what happens? The hypokalemic, hypocholoremic metabolic alkalosis condition is found. If the pre-operative alkalosis is present, then what is the difficulty we face? The time of extubation is increased and post-operative apnea is also present. That's why we always correct the dehydrations and metabolic abnormalities. After the corrections of fluid and electrolyte deficiency, we go for the surgery. Pre-operative fasting maintained. How to prepare the OT? Miller and McIntosh laryngoscope blade is ready. Endotracheal tube ready. Stellate and laryngeal mask airway also kept. We use mostly eye gel because the eye gel contains the gastric channel. When we use the eye gel, there are the risk of aspirations are less. The patient is neonates. That's why the risk of hypothermia is more in comparison to other patients. That's why we prevent the hypothermia. How to prevent? With warm blanket and maintain the OT temperature. After that, we attach the monitors like the ECG, saturation probe, and temperature probes. We put the Ryle's tube and also aspirate the Ryle's tube. Why we aspirate the Ryle's tube? Because the patient is full stomach. When we aspirate the gastric content, then empty maybe occurs. And pre-medicated with intravenous glycopyrrolate and intravenous midazolam. We pre-oxygenate the patients for 3 minutes and induced with fentanyl 1 microgram per kg, propofol 2 milligram per kg, and atracuran 0.5 milligram per kg and we do the modified rapid sequence induction. Sorry, I'm audible? Hello?
Yes,
Yes,
you continue.
Yes,
Yes.
you are audible.
Gentle smooth laryngoscopy done and intubation with 3 millimeter of endotracheal tube, which is confirmed by auscultations and capnography. Sevoflurane, oxygen and air used to maintain during the whole procedure. The good airway management is required because the patient's having the full stomach and there are the more chances of aspirations. There are the various techniques to reduce the chances of respirations. Some anesthesiologists prefer the induction with inhalational agent, and some anesthesiologists prefer the induce the patients with awake tracheal intubation. Because why the preferred some anesthetists want to awake tracheal intubation? Due to the undiagnosed airway abnormality, risk of aspirations and decreased oxygen saturations after anesthetic induction. But there are some complications in the awake tracheal intubation. What happens in awake tracheal intubation? Airway protective reflexes is present, which causes the soft tissue trauma, bradycardia, breath holding, laryngospasm, hypoxemia, and even the chance of aspiration. That's why we prefer the tracheal intubations with rapid sequence or modified rapid sequence. After that, we give the caudal block for the pain management with bupivacaine 0.1 to 5%. The IV cannulation is a problem in many children, but a good IV access is important for this surgery. In this case, only one IV cannula is present, which is not working properly. Difficult IV cannulations because the multiple attempts is taken for the cannulation. That's why we secure the central venous pressure line. In our setup, we most commonly do the brachiocephalic vein cannulation because the internal jugular vein and femoral vein cannulation is difficult to neonates due to the smaller diameter in comparison to the brachiocephalic vein. Then how to proceed the brachiocephalic vein cannulation? First, we do the position of the patients. The patients always kept in the Trendelenburg position. You can see here, the patient is the Trendelenburg position and high frequency linear ultrasound probe should be kept in the supraclavicular fossa, just above the clavicle and medial part of the clavicle. And we can see the ultrasound pictures. The IJV, internal jugular vein, subclavian vein, and this is the brachiocephalic vein. And we insert the needle, the lateral side of the probe. We can see the diameter is very large of the brachiocephalic vein. That's why the cannulation is easy, and also the guide wire is also inserted easily. And we can see here the pleura. This is also called the danger zone because the pleura is very near to this vein. That's why when we cannulate this vein, we cautiously away from the pleura. The surgery is lasted 50 minutes, and during this surgery, we maintain the temperatures and saturations and heart rate 130 to 40 beats per minute, and also maintain the urine output throughout the surgery. After completion of surgery, the neuromuscular blockade reversed with glycopyrrolate 8 microgram per kg and neostigmine 0.5 milligram per kg. After that, patient extubated and shifted to pediatric intensive care unit. In pediatric intensive care unit, we monitor the vitals and also fluid replacement therapy is given. And paracetamol 15 milligram per kg 8 hourly we given for the pain management. Post-operatively, no complaint of the pain and vitals is normal. On the second post-operative day, oral feed started, and fourth post-operative day, patient moved out of the pediatric intensive care unit, and on 8th day, he discharged from the hospital without any complication. What is the take-home message? The pyloric stenosis is not a medical emergency. First, correct the hypovolemic state, correct electrolyte imbalance, and good airway management is also required because full stomach. That's why we prefer the modified rapid sequence intubation. Thank you.
Thank you. Thank you, Dr. Poonam. I think you have managed the case very efficiently, and your case is like a typical big book picture of pyloric stenosis. So
Yes,
coming to the analysis of your presentation, I think you gave a take-home message that it is not a medical emergency. I would say that it is more of a medical emergency and not a surgical emergency, because you have to treat the fluid and electrolyte imbalance first and then take the patient up for surgery. So whenever the call comes, there is no need to hurry up. We can just resuscitate the patient, as you have already mentioned. Over 48 hours, you can resuscitate. You already said that. So you have to correct the dehydration.
Previously it is the medical emergency, but nowadays this is the surgical emergency. That's why I'm
okay. So you have to correct all those things, and without that correction, you cannot take up the case. And regarding how to resuscitate or how to correct the fluid and electrolyte imbalance, you have already explained how to correct the hypochloremic metabolic alkalosis and the hypokalemia. Everything you have told. And that is very challenging, where I think the role of the pediatrician also comes, where the correction takes place. And regarding your regarding the nasogastric tube, which you said, most often the patient comes with a nasogastric tube. So you have to, yes. Yeah, the patient comes with the exactly. The patient comes with a nasogastric. The baby comes with an NGT on table. So we have to check the position of the NGT. That is very important. Sometimes it can be misleading. It may not be in the proper position. So we have to aspirate, see whether there is any aspirate coming, and check the how much of depth it has been inserted, the nasogastric tube. And if it is not of proper size, then we may have to reinsert a larger gauge nasogastric orogastric tube. Even a 14 gauge is said it is better. And then not only that, it is better to suck or to aspirate the nasogastric tube in all positions of the baby. That's what they say, because lateral, supine, and left lateral, right lateral, that way.
Right lateral.
And even they say you can, if you are very good in doing pediatric ultrasound, then even you can do gastric ultrasound and see how much of whatever solid or liquid content is there in the gastric antrum. So that will give you an idea, so that you can plan your anesthesia technique accordingly. And as regards the induction, you have already said you have done an intravenous induction, and inhalational induction is also possible. But for the modified rapid sequence induction, I would exercise a word of caution here that your IPPV has to be very, very gentle. Otherwise, if it is vigorous, you're going to go and inflate the stomach, and then the chances of aspiration are going to increase. And as regards awake intubation is now totally not recommended. In fact, there was a study by Cook et al. Where they showed that this awake intubation is not of much use, and in fact, it will cause injury and problems and does not offer any advantages compared to the induction. That was a 1998 Cook study, which showed that the successful first intubation success rate and time to intubation is shorter when you give GA with probably a neuromuscular blocker or on spontaneous ventilation. And as regards, one more thing you have to remember is that during laryngoscopy, when you do the laryngoscopy for intubation, the chances of vomiting are very high. So at that time, the baby can aspirate. And then coming to the post-operative analgesia, I think you have given caudal block in the baby, right? So there are other modes also, like a rectus sheath block or a local wound infiltration with local anesthetic. And of course, you have given paracetamol and all for post-operative analgesia. And I think many of these babies will be premature. I think your baby was full term, luckily. So if they're preterm, then again you have to look for apneic spells in the baby for the post-operative 12 hours and so. And, there are chances of delayed recovery and all that. So that is from my side. So the take-home message would be that you have to resuscitate the baby, and as you have already told, the most important danger is the problem of aspiration, which you have to always keep in mind. Thank you.
Thank you, Madhuri ma'am, for the wonderful insights. I was about to mention many of them. And thank you, Dr. Poonam, for such comprehensive talk. A few points which I think one more thing which we need to touch upon here is the laparoscopic surgery. Many of these cases are now being done in advanced centers in laparoscopy. So concern of laparoscopy in neonates is definitely to be kept in mind in such cases. Then regarding the caudal block, which you mentioned, for the mid-thoracic levels, which will be required for such cases, for preterm infants, at least, it is not recommended to go beyond 1 ml per kg. So a better thing will be either to give caudal morphine, that is quite safe, and or go for subcostal tap, which is a very good analgesia for this procedure. Even they say wound infiltration itself is very good, especially for laparoscopic surgery. Even infiltration is good enough. If you combine with the paracetamol, that is good enough. And ultrasound, ma'am has already mentioned that ultrasound has a upcoming role. There is even a series which mentioned that the stomach contents were there and they measured and it helped in management. Thank you. That's all from my side.
Yeah. Poonam, you stop sharing the screen.
Okay. Can we move to the next speaker? So now I'll invite Dr. Pankaj. Our next speaker is Dr. Pankaj Kumar. He is a consultant in Paras Hospital, Darbhanga. And his topic is also very interesting, the role of ultrasound in appropriate endotracheal tube size selection in pediatric patients. Ultrasound has invaded all the specialties in anesthesia, and pediatric patients are no far behind. And there are many applications. Among the application, role of ultrasound in measurement of endotracheal tube size is one of the most upcoming and promising. And I now invite Dr. Pankaj to please start with this topic.
Good evening,
Full
everyone.
screen.
Okay.
Okay, continue.
Good evening,
Visible.
everyone. Good evening, everyone. The topic for discussion today is the role of ultrasound in appropriate endotracheal tube size selection in pediatric patients. As we know, we have to first tell why we require appropriate endotracheal tube size. As we know, usually pediatric patients undergo general anesthesia And usually uncuffed tube is used in infant and toddlers. If it is of small size, there are chances of inappropriate ventilation and anesthetic gas leakage. Even there is underestimation of in-tidal CO2. Whereas on other side, if it is of large size, there are chances of subglottic edema. And if prolonged, it can also lead to subglottic stenosis. So what have been used is we use formula based based on age, weight, height, or baby's finger size to calculate the endotracheal tube size. Because it is simple to apply, but it is not always suitable because the size of airway considerably varies between the patients. And clinically, what have been used is when there is no air leakage around the tracheal tube at a pressure of 10 to 30 centimeter water, we take the size of tracheal tube appropriate. So usually cuff tube minimizes this problem, but if we are using uncuffed tube, our infants or pediatric patients are prone to reintubations. We have to keep extra size endotracheal tube for the same. So I have undergone one review article which has shown that there are 12 age-based formulas for uncuffed tube, 4 height-based and 2 weight-based for the same. Whereas there are 3 weight-based formula for cuff tube and 1 based on multivariations for uncuffed tube. So for in this situation, it becomes really mind-boggling which formula needs to be used. So ultrasound has become an important tool for us. And so as per ultrasonic waves, as the ultrasound waves travels deeper to the skin, they get reflected back to a varying extent based on acoustic impedance of the tissue. Now, as we know, different body tissue have different echogenicity. So it can appear from bright white to dark. Bright white, it will be hyperechoic, and dark, it will be anechoic. Now, in case of airway, the air mucosal interface, because as we know, it is the airway, so there air is present. And so this air mucosal interface appears bright hyperechoic line. And beyond this, ultrasonic waves is not able to pass. And so due to poor, because air is a poor medium for ultrasound waves, and so visualization is difficult at greater depth. So now important thing is which tissues and what are which portion is hyperechoic. As we can see, air mucosal interface, air bubble, bone, and fat. These are hyperechoic. On the other hand, cartilage, muscle, glandular tissues, these are hypoechoic, whereas fluid and vascular structures are anechoic. So and now it's important that how pediatrics are different from adults. As that in pediatrics, anatomy is different. So ultrasound sonoanatomy, that is ultrasound anatomy interpretation is little difficult. Second, there is a lack of cooperation from the child side due to movements of neck. Third is there is since the child is of small build, so it becomes technically challenging for scanning. And even the transducer side needs to have small footprint. So usually hockey stick probe is used, as I have shown in next slide. And for doing ultrasound in pediatrics, it requires more learning. So longer learning curve is required to have a prolonged training is required for adequate imaging. This is the hockey stick probe, which is used in case of pediatrics. Now, important is at the cricoid cartilage, which is the narrowest portion, that is subglottic portion, we have to know the anatomy. As we know, cricoid cartilage appears horseshoe shaped, and since it is a cartilage, it is hypoechoic structure. So it is inverted C shape and hypoechoic. Just below cartilage, there is air mucosal interface, which is hyperechoic. And now cartilage, since it is circular and bulkiest cartilage of the larynx, so it is more anteriorly placed in compared to tracheal rings. Now the transverse diameter, which is taken at the level of subglottic space, that is at the level of cricoid cartilage, that is the size which is best calculated for the endotracheal tube size diameter. I have shown the picture here. As we can see, this inverted C-shaped structure is cricoid cartilage. Just below this is air mucosal interface shown by arrow, and this hypoechoic shadow on the either side is the cartilage continuation, and the distance I have shown in the next image. Next slide. The diameter between this hypoechoic shadow is the transverse diameter, which is the subglottic diameter, and which predicts us the idea of size of the diameter to be used. Now, since we know we have understood the cricoid ultrasound anatomy at the level of cricoid, we should also know at the level of trachea to interpret adequately the airway. So when the linear probe is placed in transverse plane just above the suprasternal notch and scanned cephalad, we can see the tracheal cartilage, and just below it is air mucosal interface, and comet tail appearance occurs due to this reverberation artifacts due to air. And when we will turn the probe 90 degree, then we can see all the tracheal cartilage arranged like a string of bead, and this gives us idea about the tracheal cartilage position, and from there we can interpret the position of cricoid cartilage. So we can see here the position of this string of bead appearance of the tracheal rings, and just above this we can see the bulky structure of cricoid cartilage. So it becomes easy to interpret the position and where the diameter needs to be taken. Now important is how to perform it. Since the child is of small size, we have to place the patient in supine position with pillow under the occiput. Same way as for laryngoscopy, and that is the sniffing position. And it is said that to achieve optimal exposure of suprahyoid structures, neck needs to be flexed, whereas for infrahyoid structures, neck needs to be extended. And for adequate scanning, examiner needs to stand on one side of the child and ultrasound machine to be positioned on the other side. We can see in this figure the position of the child and the position of the examiner and the position of the probe. Now, a few studies based on assessment, ultrasound assessment is here. First is by Kim et al. That was ultrasound measurement of subglottic diameter and empirical formula for proper endotracheal tube fitting in children. And the conclusion was that ultrasound guided measurement of outer diameter of endotracheal tube at subglottic diameter was in good agreement with actual outer diameter of tube. But in children older than 12 months, and the formula-based equation also help to select the appropriate endotracheal tubes. So in children less than 12 months, ultrasound was better in comparison to formula-based equation. Another study, which was done by Shibasaki et al., the result of prediction for pediatric endotracheal tube size was that in 98% cases of cuffed endotracheal tube, ultrasound has adequately predicted, whereas in 96% of uncuffed tube, ultrasound adequately predicted the size. Now, as we can see, the third study by J.Y. et al. In his study, it has found that the equation used based on ultrasound, there was in 60% case, it was correct size tube was taken, whereas in 31% case, there was adequate prediction was not from the ultrasound. So there is limitation of ultrasound too, and that is first that ultrasonography measures only the transverse diameter of trachea at one level. Second is that external diameter of tracheal tube varies according to the manufacturer, and thus the tracheal tube size must be assessed on individual patient basis. And third is diameter which is measured are subject to variation, inter-individual variation who is scanning the patient, and it is also time consuming due to small build of the child. So these are the limitations which led to in 40% cases the shortcomings which came for inadequate prediction of endotracheal tube size. So the conclusion is that innovation needs to be accepted, just not because it's new, but also for improvement of quality of care of the patients. And medical practice based on experience should promote pathway of innovative work. Thank you.
Thank you, Dr. Pankaj. You can stop sharing the screen, please. Excellent talk, Dr. Pankaj. I really like the conclusion that the technology only doesn't need the acceptance based on the novelty, but based on the improvement in the patient care. And as you have rightly mentioned that the ultrasound has a major limitation of being operator dependent. It is not that you just hold the probe and it will give you the idea of what tube to be chosen. It is mainly based on your skill and experience and expertise with the ultrasound. So it has a learning curve, and once the learning curve is achieved, then it is definitely a big boon to the practice. And among the various applications, the selection of the endotracheal tube is one very useful application in pediatric anesthesia. So you have mostly touched upon majority of the things, but regarding the cricoid cartilage level, the selection of the tube based on the cricoid cartilage level, one thing which can be the limitation is because the tube, it may be because some of the studies have mentioned that the glottis may be the narrowest part. The MRI based studies, they have mentioned that the glottis may be the narrowest part. So maybe that is the reason for the less sensitivity in the prediction in various studies. That may be the one limiting factor. And other very important limitation, because we are doing a study also in pediatric patients for ultrasound based assessment of airway parameters. One very important limitation is that only children more than probably 4 to 5 years would let you do the examination in awake situation. So the diameters, they also vary in awake and anesthetized state. Though at cricoid cartilage, the difference will not be much, but still that can be a one factor because the tone of the other structures will vary. And also it will vary depending on the type of anesthesia, whether you have paralyzed the child or not paralyzed the child. So all these factors do come in play. But anyways, the fact remains that it is a very, very important tool for helping us in assessment of the airway parameters in children. Thank you. Madhuri ma'am, any comments?
Yeah, I think when I read the topic, I was very happy because I have also conducted the same similar study several years back, and I don't know this, Dr. Pankaj, whether you have done ultrasound on the OT table or was it done previous day? How was it done? Was it done on the table?
Few studies have shown on the table and
on the table, yeah. So when we conducted the study, that was many years back. That time we didn't have an ultrasound in the OT. So we used to take the baby to the child to the radiology department, and there we took the ultrasound, and then we were measuring the the diameter. Okay, and then we had it was a prospective study on around 75 children, which we had done. These children were posted for elective surgeries under general anesthesia, and after doing that estimation of this tube size by ultrasonography on the table, we did clinical judgment of the tube size. And then our outcomes were to determine the correlation of the endotracheal tube size used clinically on the OT table with the endotracheal tube size estimated by ultrasound. And then we also compared it with age-based formula and height-based formula. What we found was, we found that the ultrasonography was very effective in estimating the tube size, and that was both for cuffed and uncuffed tubes. And the height-based formula was not at all effective for both uncuffed and cuffed tubes. And as regards the age-based formula by ultrasonography, the tube size estimation was comparable for cuffed endotracheal tube, whereas age-based formula for determined a larger size tube for uncuffed endotracheal tube. So it makes a lot of difference whether you're doing it for a cuffed or uncuffed tube. And one more thing which I would like to add here is on the tube, the size will be mentioned will be the internal diameter of the tube, right, in millimeters. Whereas whatever you are estimating, how do you estimate that? Like, I mean, how did you do the correlation? How did you do the correlation? That's what I want to know.
Outer diameter is correlated. Yeah.
Outer diameter.
Yes.
Okay, so every time the outer diameter may not be mentioned on the tube. That one problem we faced. And secondly, you have to use tubes of the same manufacturer, because if the manufacturer is different, then whatever it may not correlate. Did you face that problem? Did you face that problem? We face that problem. So we use tubes from the same manufacturer. Yeah, so actually this is a topic of, I don't know how clinically useful it will be, but definitely a lot of research has taken place on this topic of estimating the endotracheal tube size in children. And there are some more applications of ultrasound, airway ultrasound in children, like, especially nowadays, I think we get all obese children. So in obese children, if you want to predict a difficult airway, then you can see the amount of soft tissue or the fat in the neck in the pretracheal area. And also you can look for other pathologies like oral cavity mass or laryngeal web and all those kind of pathologies. Maybe you can use ultrasound for that also.
Ma'am, actually, I was going to mention this, that while we are doing endotracheal tube size estimation, because the child will already be anesthetized in most of the instances. So at the same time, we can just keep the probe there, and we can mark the cricothyroid membrane in case we are managing a difficult airway. That is another advantage. And also simultaneously confirming the tube placement, that both they can be done simultaneously while we are estimating. So this will provide an additional advantage. And ma'am, endotracheal tube, the outer diameter into 0.3 is the internal diameter which is mentioned.
Yes,
So that can be calculated, and that can be like in most of
that
the
can be
instances it will help.
calculated. Yes,
Yes.
yes. And the distance from the skin to the anterior aspect of the trachea, that can be measured with ultrasound.
That can be helpful.
And
Yes, ma'am.
that you can measure at 3 levels: at the level of the vocal cords, at the level of the thyroid isthmus, and at the level of the suprasternal notch. So that
And,
will help you to
even,
find out the pretracheal soft
yes, ma'am.
tissue.
Ma'am, recently they are saying that pre-hyoid soft tissue gives a better
Yes.
estimation regarding the difficulty, especially bag mask ventilation.
Yes, yes, yes. And as you said, to differentiate tracheal from esophageal intubation, and even to measure the size of the double lumen tube, there also they have
Yes.
applied
Yes.
this airway ultrasound.
Yes.
So it's
Definitely.
a very upcoming modality, very
Very
promising
upcoming.
area of research. Yes. Thank you, Dr. Pankaj. Thank you.
Ma'am, there is one question for the previous speaker. Should we address it now or later
We'll finish it off. We'll finish it off. What is it?
Ma'am, Dr. Shashikant has asked that is there any need for central line for pyloric stenosis surgery where the child is already stabilized in neonatology unit with fluid balance and having a peripheral line? Actually, I think he has not. He has missed that the child did not have a peripheral working line, so that is why the central line, and it was a difficult cannulation.
Yes.
Would the previous speaker like to add anything here? Because it is a common scenario that the line is out when the child is wheeled in. The line is already out, and on table it becomes very difficult to secure. And many times the children who are syndromic, like AMC child, it is very difficult to secure the IV line, and even we had the need to secure central line in these children.
In this case, what happens is only one line is present, and which is not working properly, and multiple puncture already done in the ward. That's why it is very difficult to cannulate. That's why we put the central line. And in our setup, we most commonly use the brachiocephalic, because in neonates, the internal jugular vein and the femoral vein is very difficult to cannulate.
Okay.
And if we cannulate, then guide wire is also stuck. That's why we prefer the brachiocephalic vein cannulation.
Dr. Poonam, by the way, we used to do many neonatal cannulations. I used to find femoral vein cannulation very easy with ladder cath cannula. I don't know what is your experience, but femoral vein used to be very easy. We just used to hold the mask and insert the femoral line with ladder cath. With ultrasound, like femoral vein is... And obviously it will not help for CVP measurement, but for central access it will help in children where it is not.
It is simpler to IJV, but many a times we stuck, and hematoma is very common in the femoral. That's why we prefer the.
Yes. Okay, that's fine.
Yeah, I think that's clear enough.
Yes.
I think we'll go on to the next speaker.
Yes, ma'am. Next speaker.
The next speaker. The next speaker will be Dr. Babli Kumari, Senior Resident, Department of Anesthesiology, RIMS, Ranchi, and he will be speaking on recent advances in pediatric anesthesia. Over to Dr. Babli Kumari.
We are not hearing you.
Audible, sir?
Yes.
My slide is visible?
Yeah,
yes, your slide is visible.
Okay. Can I start, sir?
Yeah.
Yes.
Good evening, everyone. Myself, Dr. Babli Kumari. Topic of my today's presentation is recent advances in pediatric anesthesia. As we can see, there are two pictures here. Over the left side of the screen, we can see one child which is surrounded by 3 anesthesiologists, and the patient seems to be uncomfortable, uncooperative, irritable, and might be having stranger anxiety or suppression anxiety or having pain. Whereas on the right side of the screen, we can see a child holding a mask, seems to be fearless, a little bit fearless, comfortable, cooperative, and want to be induced with the same face mask. So with the new development in the field of anesthesia, the future, we might expect we will be dealing with this type of patient. So let's learn what are the recent advances in the industry. Research and development in the field of pediatric anesthesia has significantly reduced the morbidity and mortality. Coming to the perioperative anesthetic management, ERAS. ERAS, enhanced recovery after surgery. It is an evidence-based perioperative protocol, which has proven to decrease the recovery timing and also the post-operative. It is a protocolized approach which aims in optimizing the patient health, improve the clinical outcome, increase the patient satisfaction, and decrease the healthcare cost. ERAS recommends pre-admission counseling and education, information regarding the type of surgery, anesthesia management, and recovery schedule that should be explained to the attendant. Along with that, the patient, if he is understanding about the whole information, what type of surgery he might be going, what are the anesthesia plan, what are the management, and what are the recovery schedule, should be explained in details. There are certain elements. It consists of preoperative element, perioperative element, and the postoperative element. Preoperative element comprises of ERAS education, multimodal pain management plan, optimizing the medical comorbidities, if any, avoidance of prolonged preoperative fasting, and administration of non-opioid analgesia. Whereas in perioperative elements, it consists of venous thromboembolism prophylaxis, pre-incision antibiotic prophylaxis, regional anesthesia and short-acting anesthetic techniques, minimal invasive techniques, prevention of nausea, vomiting, no use of any nasogastric tube, and there should be a standardized hypothermia prevention protocol. Coming to the post-operative element, it consists of no intraoperative perianastomotic drains, goal-directed near-zero fluid therapy, early removal of the urinary catheter, prevention of post-operative ileus, opioid-sparing pain regimen, perioperative nutritional screening, and early mobilization. Recent consensus has shifted from conservative to more liberal policy, that is NPO for giving a clear liquid 1 hour prior to the surgery. But ASA recommend that as they have insufficient evidence whether to allow the pediatric patient to drink clear liquid 1 hour or 2 hours prior surgery. It has very low evidence. Whereas to avoid we have to avoid prolonged fasting in the children, and we have to allow them to have a clear water who have low risk of aspiration as close as 2 hours before the surgery. It is a best practice statement. Now coming to the gastric ultrasound, it is a non-invasive technique, easily available. Ultrasound is easily available. Aim is to assess the gastric volume, gastric content, if it is solid or liquid, and also confirm the antral placement of the gastric tube insertion. There is insufficient evidence to support the use of gastric ultrasound for gastric volume assessment as a replacement for the traditional NPO guideline. Now coming to the next issue, that is anxiety. To deal with it, we can have a non-pharmacological approach or pharmacological approach. Non-pharmacological approach means preoperative anesthesia visit. Well, we have to go to the patient and attendant, and explaining details about the anesthesia, what we are going to give, pain management, recovery, in recovery, what we will be taking care of the patient. Other distractions like music, smartphone may be helpful in decreasing the anxiety of a child. Whereas in a pharmacological approach, if the patient anxiety is absent, no need of giving any anxiolytics. But if it is present, anxiolytics should be given. ERAS recommend not to use long-acting anxiolytics. Intraoperative management. Children, as we know, children usually have low oxygen store and high oxygen demand. So pre-oxygenation is needed. that increases the apnea period during the intubation. But it is difficult to apply. Why? Because of uncooperativeness of the patient. But if it is given, pre-oxygenation is given along with the apnea period, that provides the safe apnea period for approximately 8 minutes in older children. Now coming to the next modality, the anesthesia monitoring. With a new advancement in the field of anesthesia, new technology has been introduced that aim to provide the more accurate result. Some of them are like Massimo signal extraction technology. As we can see in the diagram, as we can see in the picture, that a children's foot is strapped with a is strapped. It is none other than Massimo signal extraction technology. What it does, that as the children are mostly mobile, they have active mobility of upper limb and lower limb. So we cannot put the probe properly and we can get the saturation. So it overcomes the challenges, and also in low perfusion artifact during the pulse oximetry, it helps in that. Other is multi-wavelength pulse co-oximeter. It monitors hemoglobin non-invasively. So it is less painful and it's good for the patient. For sicker children undergoing complex surgeries, new other modalities are being explored. Other non-invasive cardiac output monitoring in adults, esophageal Doppler pulse counter analysis, bioimpedance has been studied a lot, but in pediatric, it's being studied. Coming to the transcutaneous measurement of the carbon dioxide, it generally measures the arterial partial pressure of the carbon dioxide. As the children are more scared of the injection needles, and if we are getting the ABG, it may need multiple attempts, which may be painful for the patient, and it will be dreadful fear for the patient. So to overcome such a situation, transcutaneous measurement of carbon dioxide has been brought. Procedural sedation advantage is that it, while performing any procedural sedation without any definitive airway, it easily we can assess the partial pressure of carbon dioxide. We can avoid blood withdrawal for PaCO2 measurement, and it is patient satisfaction. In the picture, we can see there's a probe, transcutaneous measurement of carbon dioxide that is placed on the skin, while that absorbs the carbon dioxide and sensed and is measured on the monitor. Whereas the placement of these probe can be placed over the forehead, over the shoulder, over the lower abdomen wall, and over the thigh. Now coming to the pediatric airway. Pediatric perioperative cardiac arrest, that is POCA registry, and ASA demonstrated that airway complication is a major contributing factor for perioperative cardiac arrest, approximately 27%, and the brain death. Modified Mullen-Petty grading is questionable nowadays in uncooperative patients. Thus, many anesthesiologists are using Colorado Pediatric Airway Score, that is COPUR. COPUR comprises of chin, mouth opening, then previous any exposure of anesthesia or OSA, history of OSA, uvula placement, and range of motion. If the score is more than 10, it is a predictor of difficult airway. If it is 5 to 7, it is easy to intubate. If it is 7 to 10, that need a external laryngeal manipulation. One prospective multicenter trial, Nectarine. Nectarine, it is a neonate children audit in anesthesia practice in Europe that has shown increased incidence of difficult airway in less than 60-week post-consensual age that leads to hypoxemia, increased incidence of hypoxemia. Thus, a well-planned preoperative assessment of the airway is required. Another multicenter trial, VISI, video laryngoscope in small infant. It inferred that video laryngoscope has improved the first time success rate and decreases the complication. In other studies, it was found that while doing an MRI in children, the narrowest part of the larynx is found to be renal glottis. Thus, microcurved tubes are being used in pediatric population nowadays. Ultrasound is an emerging tool for selection of correct size of the endotracheal tube. But despite of this advancement, use of cuffed or uncuffed tube is still debatable. Simultaneously, simulation-based training and teamwork may help in overcoming the management of the difficult airway. Now, coming to the point of care ultrasound. It is a non-invasive diagnostic tool. Easily available, ultrasound is easily available, portable, and is evolving in the pediatric population. It is used in different fields of anesthesia, like assessing airway, assessing the lung function, cardiac assessment, gastric ultrasound, that can be a guide for critical clinical decision perioperatively. selection of appropriate size of endotracheal tube, or any pathology of airway and any palsy, something like that. A study that was conducted by Demet Alton concluded that during apnea, the measured subglottic diameter is reliable in measuring the appropriate size of the cuffed endotracheal tube in pediatric population. Limitation of this focus is it is an operator dependent skill and can deliver a false result if not performed accurately. Now coming to the next field of anesthesia, that is regional anesthesia. As ultrasound is easily available nowadays, so it has brought new opportunity for the anesthesiologist. Advantage are it is performed precisely and safely. Lower volume of drug are given as compared to the blind technique. Spread of the drug can be seen. Thus they decrease the dose of opioid use. Thus, peripheral nerve blocks are replacing genitourinaractional block. Some of the popular peripheral nerve blocks that have been used are ictus spinae block, quadratus lumborum block, transverse abdominis in the plane block, fascia iliaca plane block. Adjuncts with peripheral nerve block. Some drugs are being used to increase the duration of analgesia. Few of them are clonidine, dexmedetomidine, and buprenorphine. Clonidine increases the duration of analgesia for 4 hours. Dexmedetomidine increases duration for 5 hours, and buprenorphine increases duration for about 8 hours. But the side effect of buprenorphine is nausea and vomiting. Disadvantage for giving local anesthesia is local anesthesia systemic toxicity, most commonly neurotoxicity in children. So further studies are being conducted to assess the safety of these procedures in children. Some of the controversy on which the ASTRA and European Society of Regional Anesthesia are working are regional blocks either under sedation or general anesthesia. What should be the test dose of epidural? Identifying the epidural space either by use of air or normal saline to assess the loss of resistance. Regional anesthesia and the risk of obscuring compartment syndrome. Now coming to some pharmacological invention. One is remimazole. It is a newer ultra short acting benzodiazepine. It acts on GABA A receptor. It contains carboxylic ester that is metabolized by non-specific tissue steroids and rapidly hydrolyzed to inactive metabolites. So it is a faster onset and quick recovery. And there is a high clearance and minimal tissue accumulation. The doses are for induction 0.2 to 0.3 microgram per kg, and for maintenance 1 to 2 mg per kg per hour can be given. Next is propofol. It is a novel micro to macro approach for destabilizing the microemulsion of the propofol immediately prior to injection. It improved the stability and reduced the pain on injection in children. Another drug is articaine. It is a local anesthetic, group of local anesthetic with thiophene ring. It metabolized by esterase in tissues. T-half is 20 minutes. It has faster onset but longer duration of action. Why? Because there is increased lipid solubility and protein binding capacity of the drug is high. Tiva has been significantly increased. Use of Tiva in pediatric population is increased since last decade. Now there is some concern by FDA about association of neurocognitive abnormality and the use of general anesthesia in child. 3 prominent prospective study, that is MASK, GAS, and PANDA. MASK stands for Mayo Anesthesia Safety of Kids. GAS stands for General Anesthesia and Spinal, and PANDA is a Pediatric Anesthesia Neurodevelopment Assessment. All 3 of them concluded that single use of general anesthesia was safe in children. But MASK and PANDA, they also concluded that with multiple exposure of general anesthesia, there was neurodevelopmental defect. Cause was not known. But GAS suggested that other factor may be the cause of neurodevelopmental abnormality that can cause neurodevelopmental abnormality in child. That can be a prolonged duration surgery or large hemodynamic fluid shift during the surgery. Now coming to the pediatric advancement life support. As we know, this guideline usually updated every 5 years. Last updated edition was 2020. So this update discussed on pre-arrest, intra-arrest, and post-arrest. Pre-arrest recommend the use of extracorporeal life support and extracorporeal pulmonary resuscitation in children with acute myocarditis with arrhythmia, heart block, ST segment changes, and low cardiac output with the idea of avoiding the onset of the cardiac arrest. In intra-arrest care, the guidelines suggest early administration of adrenaline within 5 minutes for non-shockable rhythm. The most important change was higher respiratory rate, 20 to 30 breaths per minute in children who are receiving CPR with advanced airway and during rescue breath. Cuffed endotracheal tube was found to be reasonable as they decrease the need of tube change, and we should pay attention toward the size selection, position, and the cuff pressure of the tube. The use of cricot pressure is not at all recommended as it does not reduce the risk of regurgitation and may impede the intubation success. Another naloxone. Naloxone has been added to the reversing the respiratory arrest due to the opioid overdose. In post-arrest care, return of spontaneous circulation emphasized on the maintaining homeostasis and target temperature monitoring management. Next is sepsis. The flow resuscitation has been modified, that is from bolus 20 ml per kg to 29 ml per kg of isotonic crystalloid with continuous monitoring. But if the patient is having the refractory septic shock, early addition of the adrenaline and non-adrenaline in the fluid has been recommended. So this is the total key point of this presentation. ERAS has been introduced, fasting guideline that has changed somewhere about for 1 hour for the clear fluid, the role of pre-oxygenation and apneic oxygenation in children while intubation, and certain advancement in the field of monitors. Central neuraxial block has been replaced, have been replaced by peripheral nerve blocks. Certain advancement in the field of pharmacology, and certain discussion about the effect of anesthesia drug on neurodevelopmental abnormality of a child, and AHA PLS guideline changes has been discussed here. Thank you. Hello.
Thank you, Dr. Babli Kumari, for all the detailed presentation regarding the recent advances which have taken place in the field of pediatric anesthesia. I think you have told quite a few advances, and I think you started with ERAS very rightly, because nowadays I think everywhere we are hearing about ERAS. ERAS is a very common topic in conferences, and it's a very hot topic of discussion, and everybody is trying to implement ERAS. Various steps of ERAS are being tried to be followed, and I really do not know how much successful we have been or we will be in implementing the various steps of the ERAS protocol. But there is no harm in trying, and I think especially in the success rates are different when the different fields of anesthesia are concerned. And as regards ramimazolam, yes, ramimazolam appears to be a very promising agent for pediatric anesthesia, and it has been found to have a very rapid onset of action and provides very good sedation and very early recovery, and the respiratory depression is also very, very minimal, and there are studies which have shown that it reduces the emergence delirium, post-operative emergence delirium, especially, for example, following sevoflurane induction in children. So I think it will become a very popular agent in pediatric anesthesia once it comes here. And I think that will be a big boon to ERAS also, because in ERAS we need rapid recovery and no respiratory depression and all those things. And as regards micro-cuffed tubes, yes, I do agree. Micro-cuffed tubes are really very useful, because they provide a very good seal of the airway, and you can even use low flow anesthesia when you use these kind of tubes, and reduce pollution and good economy of gases and cost of anesthesia. And but one thing regarding micro-cuff tubes is that you have to put the proper size tube as per the manufacturer recommendations. That is very important. And secondly, cuff pressure monitoring is very important. So you have to regularly monitor the cuff pressures when you use a micro-cuffed tube. And yeah, thank you. That is from my side.
Thank you, Dr. Babli. Nice presentation. Regarding ERAS, there are few components which are not applicable to pediatric patients. So we need to be aware of them. One of them is the nasogastric tube drainage early removal. That is one of the components. And also regarding the pharmacology, I think Sugama Dex is one very important recent advances in pediatric patients, because it is a very important tool which is available nowadays in difficult airway management, especially because succinylcholine may not be advisable for many pediatric patients, and that is the only thing which we can use in a difficult airway management if we need to use muscle relaxing. So availability of Sugama Dex in India, I think it is going to be a very big boon for us in difficult airway management. And it has become very cheap also recently. It is available only in 750 rupees. So that is one thing which I am looking forward to using in pediatric patients. And rest, most of the things are well touched by you. And I think well done. Thank you.
Thank you, ma'am.
Anju, I just wondered whether the Sugama Dex has received approval for use in children. US FDA approval. Sugama Dex children. There are so many studies, but whether
so
it
many
has
studies,
received,
yes, ma'am.
Because few years back it had not received in children, so I'm not aware right now.
I'll also have to check regarding that.
Yeah, we'll have to check.
I think it is not approved as of now, but
it is a big
since
boon,
there are
as
so
you
much
told,
of literature. Yes, ma'am.
Yes,
so much of literature regarding its safety in pediatric patient is available now, so we can go ahead and use it. Because things like intrathecal fentanyl is also not approved FDA, so we need not wait for that. Yes,
definitely.
yes.
And especially when you don't want to use choline, then it is a big boon, because you can use urocuronium and along with that you can use Sugama Dex. Yes.
Yes, ma'am. Yes, ma'am.
Yeah, thank you. It was
a question.
There is a question.
I think there was only one question which is there in the chat. What is the fluid protocol which you follow 4-1, and how do you manage pre of fasting fluid? I think Dr. Bubbly mentioned the fasting fluid, that we are now going for 1 hour fasting, and 1 hour fasting is universally accepted now. Even a 0 hour fasting was mentioned in one of the societies. They are going ahead with 0 hour fasting also. But as of now, at least the 1 hour fasting is definitely gained a universal acceptance, and that is being followed world over. All the major societies have recommended 1 hour fasting period. So that is definitely a go ahead. And regarding the fluid management 4-1, now I think many people have moved ahead with the rule of 10, which was recommended by the German Society. And it came in an article in 2016 in Pediatric Anesthesia. Dr. Bubbly, would you like to add to that?
Actually, here, ma'am, we used to follow 1 hour NPO guideline, clear fluid. We allow the patient to have 1 hour prior to the surgery, ma'am. And for 4-1, ma'am, we still follow 4-1 protocol in our institute, ma'am.
Okay. That's fine.
Okay, it's okay.
That's fine.
Institutes are
Many
still
people are
following the
following.
holidays. No
Yes.
issues. Yeah.
Yes, yes.
Yeah. Okay. So whether Naveen Malhotra sir is there or not? Rekha ma'am?
Yes, I am there.
Yeah. Rekha ma'am. So please conclude the session, and we will just deliver the certificate to our moderators, and moderator will deliver certificate to our speakers.
I think this has been an excellent session. All the 3 talks have been on varied topics on the pediatric anesthesia. Some has been the last speaker has rightly, Dr. Bubbly has rightly pointed out all the recent advances, and our other speaker, the Dr. Pankaj, he spoke on it's more of a research topic. He spoke on how to get an accurate measurement of the endotracheal tube in a pediatric age group, because we all understand the importance of the tube size in the pediatric age group and the damages it can cause because of the wrong estimation. And Dr. Poonam's talk also was very relevant regarding the occurrence of the incidence of, I think she spoke on, can you tell me, Dr. Anju, she spoke on
Doctor? Dr. Poonam Kumari.
Spoke on, yeah. She spoke on
Pyloric stenosis.
Pyloric stenosis.
Yes. And the
difficult airway management.
The high incidence of pyloric stenosis that occurs with the younger age group and how we manage it. And of course, it has been rightly modified and rightly moderated. In an emergency situation, we mostly encounter this situation sometimes in an emergency, and how she has so well explained how you manage it in a medical management is done, followed by the surgical management. And the talks have been so varied and so interesting that really must have sent even good lessons to all the postgraduate students. And the moderators have done an excellent job. They have put in some extra points left out by our speakers, or they have given their inputs about the latest innovations or latest whatever has been done on this topic. And I again thank the Bihar and Jharkhand group for doing an excellent session on pediatric anesthesia. I myself am not very much good at pediatric anesthesia for myself, because I mostly deal with oncology, and therefore I have been pretty interested by some new innovations that has been put up by Dr. Babli, and some new drug which I myself had not known its importance in the pediatric age group. Thank you all the speakers. And thank you, Dr. Madhuri and Dr. Anju, for giving such wonderful highlights on this topic. And thank you again, Bihar Jharkhand group, for this excellent academic show that has been put up.
Ma'am, please give the certificate to the moderator, ma'am.
Yes, this is, I now present, I award Dr. Madhuri Kudi for this wonderful moderation on safe pediatric anesthesia.
Thank you, ma'am. Thank you. Thank you.
Now,
Madhuri needs no introduction. Actually, she's such a wonderful academician. And now I would present this certificate to Dr. Anju. Now
Anju,
over to
next.
Anju. I thought the slides, yes. Now over to Dr. Anju Gupta. Another,
thank you so much,
another, I think, jewel in the crown today, the second jewel in the crown today. And I present on behalf of the Bihar and Jharkhand group the certificate of participation as a moderator. Excellent moderation, Dr. Anju.
Thank you so much, Rekha ma'am. Thank you so much for the kind words. And my sincere gratitude to the Bihar and Jharkhand Society of ISA for giving me this opportunity to moderate the session. And it has been an enlightening session for me and all of us. I think pediatric anesthesia safety is the foremost important. And I think we have got the right message through this CME. I congratulate Dr. Jay Prakash and his team for such wonderful organization and wonderful topics. Thank you very much.
thank you. So, thank
A
you.
big round of applause to Dr. Madhuri
Big round
and
of
Dr.
applause.
Anju
Yes.
for a very nice moderation.
Yeah.
Thank you, ma'am. Thank you so much.
Thank you, ma'am.
Yeah. Manoj boss.
Dr. Manoj.
Yes.
Yeah. Please deliver the certificate to Dr. Poonam.
Okay.
All.
Hello. On the behalf of Bihar Jharkhand Society of Anesthesiology, please accept certificate to Dr. Poonam Kumari, from Associate Professor from the AIMS Patna. Dr. Poonam, please accept
Thank you, sir.
certificate of participation from the Bihar and Jharkhand Society of Anesthesiologists.
Now, please deliver certificate to the Pankaj, Dr. Pankaj Kumar.
Dr.
Next
Pankaj,
speaker.
Dr. Pankaj Kumar delivered very nice presentation. So on the behalf of BJSA, kindly accept the certificate of participation
Please change
to Dr.
the certificate.
Pankaj Kumar.
Thank you, sir. Thank you.
JP,
Thank you.
change.
Yeah,
Okay.
now
Okay. Next speaker.
now please deliver the certificate to Dr. Babli.
I will present to certificate of participation to Dr. Babli Kumari on the behalf of BJSA. So kindly accept certificate of participation to Dr. Babli.
Thank you so much, sir.
Dr. Manoj, please say few words regarding the CME and give few inputs.
I congratulate the whole team of Bihar Jharkhand, especially Dr. B.K. Prasad sir, Dr. Ajay Kumar, secretary, and JP, Dr. Jay Prakash as a scientific secretary, Dr. Nishant, Dr. Prasant, and many more of executive body of the Bihar Jharkhand Society and member of BJSA. So I warm welcome to Dr. Rekha Das Madam, Dr. Naveen Malhotra sir as a chief guest, Rekha Das Madam as a guest of honor, and thank you very much, Dr. Madhuri Kurdi Madam, for coming and moderating the session very nicely. And thank you to Dr. Anju Gupta Madam. You have done very good job and give very nice input to our BJSA members. So I request to both of you, so whenever we call, please come and attend as a moderator, as a chairperson, as a guest of honor. So please come and touch with BJSA family. So thank you, JP. Thank you, Ajay Boss. Thank you, B.K. Prasad sir. And
we, Dr. Manoj, Dr. Hari Damodar sir and Dr. Sushil sir with us, because this is the term of Darbhanga city branch, and Damodar sir is also here and Dr. Sushil sir is also. That's
why I'm very thankful to Dr. Sushil sir. He is my teacher, and Damodar boss, he is my senior and also teacher. Warm welcome, Sushil sir and Damodar sir.
Good evening. Good
I would
evening.
like to call Dr. Sushil sir for a vote of thanks to everyone, sir.
Good evening, everybody. A very nice academic feast this evening. I thank each and every participant, as the speaker, as the moderator, as the listener. We learn so many things. A very nice presentation, very well organized. And this time I didn't find much of other disturbances like audio or video disturbances. A good quality presentation. Thank you, everybody.
Thank you, sir. Thank you.
Dr. Ajay Boss. Dr. Ajay Boss.
Yes, sir.
Some few inputs from Damodar boss.
Yes.
Good evening. Nice
Damodar.
presentation by all the three persons, and they really spoke about some recent advances. That was very nice. One thing I was missing, the number of participants. We should encourage our PG students to participate at least. We should make it mandatory or promote them anyhow to participate, because they are the new batch who will come and deliver these lectures, and they will get the most benefit from. Okay, very nice presentation this time.
Yes, boss, sir. Approx 72 participants.
Yes. The peak was around 70.
Okay, now we are closing the session. Thank you all.
Thank you.
Thank you all.
Thank you.
Thank you very
Good
much.
night.
Thank you and good
Thank you,
night.
Dr.
Thanks a
Jayaprakash and
lot.
team. Thank
Thank
you.
you.
Thank you, Madhuri ma'am. Good
Thank
night.
you. Thank you.
Thanks,
Good night.
everyone.
Thank you, everyone.
Good night, everyone.
Thank you, Rekha ma'am.
Good night.
Thank
Good
you.
night.
Thank you to all.
Night.
Good night.
Madhuri madam, good night. Anju madam, good night.
Thank you. Thank
Good
you.
night.
Thank
Good
you,
night.
sir. Thank you.
Good night,
Good night.
everyone.
Thank you. Good night.
Thank you, everyone.
जेपी 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 है कि निकल गया? है ना? अभी
Still many people are there. So admin, please.
एडमिन को उनको बताना पड़ेगा ना।
Admin.
तुम एडमिन को बोल के
Wait,
तुमको
wait.
होस्ट
हम कर देते हैं, बॉस कर देते हैं. I already planned that. Let me call her.
अजय बॉस,
Yeah.
हाँ
हम रिक्वेस्ट किए सभी को कि बिहार झारखंड दरभंगा सोसाइटी ऑफ एनेस्थेसियोलॉजिस्ट का जो कॉन्फ्रेंस दरभंगा में होने जा रहा है,
कर देता हूँ.
हाँ, तो उसके लिए थोड़ा जल्दी लोग रजिस्ट्रेशन करवावे.
हम लोग अभी बस थोड़ी देर में हम लोग उसी पर डिस्कशन करेंगे.
जी जी.
अभी हम लोग उसी के लिए. शरद बॉस आए कि नहीं? शरद बॉस ऑनलाइन है, लेकिन वो
ठीक है.
ऑनलाइन अभी रहना है. भुवनेश्वर
मनोज है कि चलेगा? डॉक्टर मनोज.
हाँ, मनोज है सर. सर अपना फोटो दिखाइए सर, विजेंद्र सर. वीडियो वीडियो को अनम्यूट कीजिए सर.